Good afternoon, everybody. With great pleasure, I introduce Dr. Suma Krishnan. Dr. Suma Krishnan is a medical retina consultant and a comprehensive ophthalmologist at Zamindars Microsurgical Eye Centre. She has over 20 years of experience in comprehensive ophthalmology and medical retina. She's an alumni of the prestigious Arvind Eye Care System. And in interest of time, I will hand it over to Dr. Suma Krishnan for telling us more about how diabetes can affect our eyes. We are all ears, Dr. Suma. This webinar is getting recorded. And in any case, if anybody wants a copy of the webinar, please do message us and we'll be very happy to share that with you. Thank you so much. Dr. Suma Krishnan, over to you. Please go ahead.
Thank you, Dr. Zamindar, for that introduction. Good afternoon, everyone, and a warm welcome to all of you. I'm so glad and honored that some of you have been able to take time off from your busy practice to listen to me this afternoon. Today, I will be talking to you about diabetic retinopathy, which is a topic which will never lose its relevance, especially since India is racing its way to the unfortunate title of the diabetic capital of the world. Before talking about diabetic retinopathy, I'd like to highlight the diabetes-related disease burden in India. Diabetes is fast gaining the status of a potential epidemic in India. An estimated 77 million individuals were diagnosed with the disease in the year 2020. And these numbers are projected to increase to 134 million by the year 2045 as per the International Diabetes Federation. Coming to the etiology, it is multifactorial, which includes genetic factors and environmental influences, such as obesity, which is associated with rising living standards, steady urban migration, and lifestyle changes. Rough estimates have shown that the prevalence of diabetes in the rural populations is 1/4 that of the urban population in India. So urban migration seems to play an important role. Diabetic retinopathy is the specific microvascular complication of diabetes, and it is the commonest cause of legal blindness between the ages of 20 and 65 years. A meta-analysis of large-scale studies shows that approximately 1/3 of those with diabetes will have diabetic retinopathy, and approximately 1/3 of those, or 10% of patients with diabetes, will develop vision-threatening diabetic retinopathy that requires treatment. Now, coming to the risk factors, the duration of disease is the most important risk factor for development of diabetic retinopathy. It is a strong predictor of maculopathy and proliferative disease. In patients diagnosed with diabetes before the age of 30 years, 50% develop diabetic retinopathy after 10 years, and up to 90% develop diabetic retinopathy after 30 years. Poor metabolic control is the next important risk factor. It is less important but relevant to the development and progression of diabetic retinopathy. Early tight control can prevent or delay progression. Raised HbA1c is associated with increased risk of proliferative disease. Hypertension is very common in patients with type 2 diabetes, and strict control of hypertension is especially beneficial in patients with maculopathy. Pregnancy is also associated with rapid progression, the predicting factors being poor pre-pregnancy control of diabetes, too rapid control in early stages, preeclampsia, and fluid imbalance. Nephropathy is also associated with worsening of diabetic retinopathy changes, and treatment of renal disease may be associated with improvement of diabetic retinopathy and better response to photocoagulation. Some other risk factors are obesity, increased BMI, high waist to hip ratio, hyperlipidemia, and anemia. Diabetic retinopathy is a microangiopathy which exhibits features of both microvascular occlusion and microvascular leakage. Degeneration and loss of pericytes leads to capillary wall weakening. This in turn results in plasma leakage, which is seen clinically as retinal edema. Chronic retinal edema results in the formation of hard exudates at the junction of the normal and the edematous retina. Capillary wall weakening also is responsible for the formation of microaneurysms, which are the earliest sign of diabetic retinopathy. Capillaropathy occurs in the form of endothelial cell damage and capillary basement membrane thickening. Hematological changes like increased plasma viscosity, deformation of RBCs, and increased platelet stickiness predispose to decreased capillary blood flow and perfusion. This in turn leads to hypoxia. Microvascular occlusion thus results in the formation of arteriolar venular shunts or intraretinal microvascular abnormalities seen in severe non-proliferative diabetic retinopathy. Further, the release of angiogenic growth factors results in the formation of new vessels. New vessels on the iris are called proboscis iridis, and new vessels on the disc and elsewhere are features of proliferative diabetic retinopathy. Vascular endothelial growth factor is a key player in the process of neovascularization in proliferative diabetic retinopathy. Now, coming to the classification, diabetic retinopathy is broadly of two types, non-proliferative and proliferative. And non-proliferative diabetic retinopathy is graded as mild, moderate, and severe. So here are some fundus pictures showing eyes with mild, moderate, and severe non-proliferative diabetic retinopathy. And the last picture shows a clinically significant macular edema, which I will be describing shortly. What are the signs of non-proliferative diabetic retinopathy? These are the hallmarks of NPDR. They are microaneurysms, retinal hemorrhages, hard exudates, cotton wool spots, venous beading, and intraretinal microvascular abnormalities. I'd like to briefly describe each of these lesions. Microaneurysms are localized saccular outpouchings of the vessel wall where pericytes are absent, and it's the earliest sign of diabetic retinopathy. They are seen as small red dots all over the fundus. Flame-shaped hemorrhages arise from the larger superficial precapillary arterioles, and they are flame-shaped as they lie in the superficial nerve fiber layer of the retina. Dot and blot hemorrhages arise from the venous ends of the capillaries and are located within the compact inner layers of the retina. These are also seen as red dots, but are larger in size than microaneurysms. Hard exudates are intraretinal lipid accumulations that leak from surrounding capillaries and microaneurysms. They are yellow in color and are arranged in clumps or rings, typically surrounding leaking microaneurysms. Cotton wool spots are nerve fiber layer infarcts. They're also called soft exudates, and they have a fluffy yellow appearance. Venous beading is a sausage-shaped dilatation of the retinal veins, and it is a sign of severe non-proliferative diabetic retinopathy. IRMA or intraretinal microvascular abnormalities are arteriolar venular shunts that run from retinal arterioles to venules, and they are seen adjacent to areas of capillary closure. They are a sign of severe non-proliferative diabetic retinopathy. Diabetic maculopathy is a cause of visual loss in diabetic retinopathy. It occurs in the form of macular edema, which is due to increased retinal vascular permeability, or macular ischemia due to retinal capillary non-perfusion. The top left photo shows a ring of hard exudates, and the corresponding fluorescein angiography image on the right shows leaking microaneurysms leading to focal retinal edema. The bottom picture shows severe non-proliferative diabetic retinopathy with the angiogram showing diffuse leakage. This is the optic disc, and the fluorescein angiography image depicts a leakage from the disc and significant non-perfusion areas of the macula, signifying macular ischemia. The definition of CSME, or clinically significant macular edema, was the single most significant outcome of the early treatment diabetic retinopathy study, and it described in detail the significance of the location of hard exudates with respect to the center of the fovea and the presence of associated retinal edema. Now we come to proliferative diabetic retinopathy, which is characterized by neovascularization on the disc and elsewhere on the retina. By now, we've come a long way in the course of diabetic retinopathy. Now the microvascular occlusion has led to hypoxia, there is release of angiogenic agents, and widespread new blood vessel formation. What we would like to see are pictures, fundus pictures like this when we see our patients rather than this. Here comes the role of the physician, that is your role. Patient education is crucial. They must be told that diabetic retinopathy can present even if the vision is good. that routine eye checkup for glasses by an optician will not reveal diabetic retinopathy, and that periodic retinal examination is the key. So here is a simple schedule for eye examination in case of diabetics. So if diabetes is detected below the age of 30 years, the first screening must be within 5 years of diagnosis and yearly thereafter. If detected after the age of 30 years, it's mandatory to undergo a detailed retinal evaluation at the time of diagnosis and yearly thereafter. I'll be elaborating on this a little later. Diabetic pregnant women must be evaluated once every trimester. Now I come back to proliferative diabetic retinopathy. These are fundus pictures showing proliferative diabetic retinopathy with neovascularization on the disc and neovascularization elsewhere. These are some of the vitreous changes associated with proliferative diabetic retinopathy. The one on the left shows subhyaloid vitreous hemorrhage and with neovascularization of the disc. And the one on the right shows a fresh vitreous bleed obscuring visualization of the retina. These are some more pictures to show how badly diabetes can affect the eye. This patient seems to have undergone a pan-retinal photocoagulation but has still ended up with a vitreous bleed. This proves that regular follow-up is essential, and just because pan-retinal photocoagulation has been done, it does not mean that no further damage can occur. The next picture shows a tractional retinal detachment with multiple fibrous bands. End-stage disease may result in rubeosis iridis, and a painful blind eye due to neovascular glaucoma. That would be the sad end to our diabetic retinopathy story. Now, coming to the signs and symptoms of diabetic retinopathy, patients with diabetes may present with blurred vision or distorted vision or difficulty in reading. They may have floaters, which could signify the onset of a vitreous hemorrhage. A partial or total loss of vision may be the sign of a vitreous hemorrhage or diabetic retinal detachment. They may even present with eye pain in case of neovascular glaucoma. This is a picture which shows the image seen by a patient with vitreous hemorrhage. They see blotchy black spots in their field of vision. Now we come to the most important aspect of this talk. How does one diagnose diabetic retinopathy and diabetic macular edema? This is done by conducting a comprehensive eye examination, which includes visual acuity assessment, slit lamp biomicroscopy, intraocular pressure measurement, gonioscopy when indicated, dilated fundoscopy, including stereoscopic examination of the posterior pole, examination of the peripheral retina and vitreous, fundus photography, fluorescein angiography, optical coherence tomography, and ultrasound as indicated. So applanation tonometry is the gold standard for intraocular pressure measurement and can be done at the slit lamp or as seen here with a handheld Perkins tonometer. Gonioscopy is performed at the slit lamp using a gonio lens. A non-mydriatic fundus camera is a novel way of screening for patients patients with diabetic retinopathy who are not willing for a dilated retina evaluation. In case one detects changes, a dilated examination is warranted. Optical coherence tomography is a non-invasive procedure to obtain high-resolution cross-sectional images of the retina. It has become the most important tool in diagnosis and management of macular pathology. As you can see in this picture, the patient is seated comfortably at the machine and the test does not take more than a few minutes. The image on the left shows the normal foveal contour with compact arrangement of the retinal layers, and the right figure shows a pathologic macula showing the presence of intraretinal cysts and the collection of subretinal fluid. Fluorescein angiography is a technique for examining the circulation of the retina and choroid using a fluorescent dye and a specialized camera. It is no longer as commonly indicated as in the past. It is now reserved for cases that present as diagnostic dilemmas. The image on the left is an early phase of the angiogram showing microaneurysms appearing as white dots all over the central fundus, and the image on the right shows retinal blot hemorrhages, which are seen as dark spots. These are late images of the angiogram showing leaking from the disc and elsewhere, signifying proliferative diabetic retinopathy. Now we come to the treatment options. First and foremost would be medical treatment, in which you as physicians will play a major role. Then comes laser photocoagulation, intravitreal injections and implants, and finally surgery. So the medical treatment, I'm sure all of you are doing this day in and day out in your practice, but the gist would be to control the blood sugars, control the blood pressure, control lipids, correct anemia, and control diabetic nephropathy. Ever since the early treatment diabetic retinopathy study showed that photocoagulation reduced the risk of moderate visual loss by 50% in patients with clinically significant macular edema, it has been advocated in the form of focal or grid laser. Pan-retinal photocoagulation is reserved for patients with proliferative diabetic retinopathy. In focal laser photocoagulation, the leaking microaneurysms are hit directly with laser energy leading to their closure. The white arrow shows the focal laser scars. The second picture shows pre and post treatment images of the retina showing resolution of the edema and absorption of hard exudates. Here, grid laser photocoagulation is done to treat diffuse macular edema. Pan-retinal photocoagulation is reserved for patients with proliferative diabetic retinopathy and neovascular glaucoma. The peripheral retina is ablated with 1,200 to 1,600 retinal burns of size 500 microns, placed one burn width apart. The central retina is left untreated. Here is a picture of the fundus following a pan-retinal photocoagulation. The introduction of anti-VEGF agents has brought about a paradigm shift in the treatment algorithm of diabetic macular edema. These agents target specific isoforms of VEGF or vascular endothelial growth factor. Lucentis and Avastin have been available in the market for some time now. Eylea is also FDA approved for the treatment of diabetic macular edema and is available in India. The procedure of intravitreal injection is simple and relatively painless. Iluvien and Ozurdex are steroid-releasing implants that are indicated in special situations. Surgery, the broad indications for surgery are persistent vitreous hemorrhage and tractional or combined retinal detachment. It is a day care procedure and may involve special postoperative positioning if an oil or gas is injected. These are broad guidelines for follow-up schedule and management. If no diabetic retinopathy is detected, one can continue with yearly eye examinations. The same is in cases with mild non-proliferative diabetic retinopathy. Moderate non-proliferative diabetic retinopathy will require closer 6 monthly follow-ups. Severe non-proliferative diabetic retinopathy requires 3 to 6 monthly follow-up, and cases with proliferative disease will require an urgent PRP, and patients with the diabetic macular edema require treatment in the form of anti-VEGF injections or laser. Retinopathy and diabetic macular edema can be predictors of other diabetic complications. Proliferative diabetic retinopathy is an independent predictor of nephropathy and is associated with increased risk of all-cause mortality or cardiovascular events. Patients with diabetic macular edema have a 2-fold higher risk of cerebrovascular accidents and a 2.5-fold higher risk of myocardial infarction. From a healthcare perspective, assessment of the current glycemic status and the burden of diabetes-related complications is important in order to allocate community and health resources in any country. Such data is limited from developing countries like India. So here comes the role of the physician in putting together such data. To summarize, patient education is very important. They need to understand that retinopathy is possible even with good vision, optimize their blood sugar and the blood pressure. Good control does not necessarily reduce the lifetime risk of developing diabetic retinopathy, so everyone with diabetes is at risk. Timely intervention and referral to the ophthalmologist or the retina specialist is crucial. And before I end in the context of diabetic retinopathy, I'd like to go to Robert Frost. Thank you for a patient hearing. Thank you.
Thank you very much, Dr. Suma Krishnan. I think this was really an eye-opener. And I have a question for you, and request anyone else who has a question, please go ahead and keep your question ready. Isn't it sad that India is the diabetic capital of the world and really nothing has been done to change something about this lifestyle disease? It is even more sad as an ophthalmologist that I see that the referral for diabetic eye checkup does not come very easily from physicians. And in India, not only that allopathy doctor treats diabetes, but Unani, homeopathy, Ayurvedic, almost every other person is treating diabetes, but creating awareness about diabetic eye checkups is really, really very less. At Zamindars Microsurgical Eye Centre, we have now decided that no more avoidable blindness. And that's the reason why we requested Dr. Suma Krishnan to take this very important talk. The recording of this webinar is going to be a must-see for every treating doctor who treats diabetes. And we will ensure that it's there in our website, it's available in all our social media handles, and request each one of you to personally see that this recording reaches every doctor you know who treats diabetes. The question for you, Dr. Suma, is that would it be right if I say that only people who are not very cannot really afford treatment or are not educated suffer from diabetic retinopathy, or people who are educated and well affording can also do suffer from diabetic retinopathy? Do you think that the awareness in educated people is more, and something on those lines? Can you please take that question?
No, so like I said in one of the slides that because of a lot of urban migration that's happening in today's day and age, so a lot of the urban population also suffers. I mean, the prevalence of diabetes in the rural population is 1/4 that of the urban population. And unfortunately, the rural people who have shifted to the urban population have a more, the prevalence is increasing in them because of the same risk factors. So I think that, so as you rightly pointed out, in spite of the fact that people are aware of things, we do see on a day-to-day basis, we see educated people coming who have, whose sugars are so badly controlled. In fact, just this morning, I had a gentleman and his mother, both of them had HbA1cs of 9.31 was 9.3, one was 10. So it is sad, but so and they have not got an eye checkup done in the last 1 or 2 years. So awareness, I think, has to be improved, and and like such discussions will help when we can also tell the practitioners and general practitioners to send patients to all eye doctors for
Thank you, Dr. Suma. And I wanted to inform everybody that under the able leadership of Dr. Suma Krishnan, we have a complete medical retina department at Zamindars Microsurgical Eye Centre for early diagnosis and treatment. And we, of course, take care of people who can afford, but people who cannot afford treatment, we have Thursday OPDs for them, and we have last Thursday of the month reserved for diabetic patients. Any diabetic patient can walk in and we can do a complete eye checkup. This is a project we have taken along with Rotary Kalyan Nagar. And please do share this piece of information also with people so that they come in and take use of our Thursday OPDs. Every Thursday we have that between 3 to 6 at Zamindars Eye Centre, Kalyan Nagar. And the last Thursday of the month, the complete day at the new center, Prema Plaza, 2nd floor, is a completely free screening for diabetic patients. If anybody else has any question, please go ahead. Otherwise, in interest of time, we will wrap up. And I do thank Dr. Suma Krishnan for her valuable time and support. Thank you so much.